Good morning all, and today what we're going to discuss is adrenal disorders. The objectives of this session is as follows. Describe the clinically important adrenal disorders. Describe the clinical presentation of these disorders. Describe the management of these disorders as well as the methods to diagnose these disorders. So the adrenal gland is a triangular shaped gland that is located on top of the kidney. Each gland, which is on either kidney, right, has both a cortex and a medulla. The medulla is responsible for secreting epinephrine and norepinephrine, and the cortex secretes mineralocorticoids like cortisone and aldosterone. The adrenal hormones include hydrocortisone, which is responsible for regulating metabolism, glucocorticosteroids or corticosteroids, which decrease inflammation, maintain blood pressure and cardiovascular function, maintain blood glucose, and regulate metabolism. The mineralocorticoids like aldosterone, which inhibit sodium secretion into the urine and maintain blood volume and blood pressure. And of course, epinephrine, which increases heart rate, contractility, facilitates blood flow to the muscles and the brain, causes relaxation of smooth muscles, and helps conversion of glycogen to glucose in the liver. All these are to respond to some kind of a stimulus, the fright, flight, and fight response. Norepinephrine is vasoconstrictive and therefore increases blood pressure and is also responsible for preventing you from developing shock. Essentially, when you see something which is scary, like a snake for instance, your nervous system then sends a message to your adrenergic gland, right, which sits on top of your kidney, or your adrenal gland, which sits on top of your kidney there. And also ACTH is released, adrenocorticotropic hormone is released, which then again stimulates your adrenal gland to release epinephrine. Epinephrine then increases your heart rate and your blood and your breathing rate and your blood sugar rate, and increases blood glucose levels, etc. And it's just so that you can get a fright, and then you can run away or you can fight whatever is in front of you. Glucocorticosteroid excess, of course, leads to a increase in glucose production to give you the energy to be able to do all of this. So it's fright, flight, and fight. Now, the adrenal disorders either come from hyperfunction of the adrenal gland involving excessive production of adrenal hormones such as cortisol for causing Cushing's syndrome, or aldosterone, which leads to hyperaldosteronism. Hypofunction of the adrenal gland is associated with primary hypoaldosteronism or Addison's disease, or secondary hypoaldosteronism. Of course, you can also have adrenaline secreting tumors which sit on top of the adrenal gland itself, called pheochromocytomas, which is another thing that we will discuss during this lecture. So let's start off by discussing Cushing's syndrome. In Cushing's syndrome, this results from supraphysiological glucocorticoid levels, and it either originates from exogenous administration of glucocorticoids in the form of glucocorticosteroids, or alternatively exogenous overproduction by the adrenal gland in ACTH-dependent tumors, or alternatively from abnormal adrenocortical tissue, which is ACTH independent type tumors. ACTH dependent Cushing syndrome forms 80% of all forms of Cushing syndrome cases, and is caused by an overproduction of ACTH by the pituitary gland, causing adrenal hyperplasia. Right? Pituitary adenomas will account for about 85% of all Cushing syndrome cases, right? And ectopic ACTH secreting tumors and non-neoplastic corticotropin hypersecreting tumors can cause about 20% of ACTH dependent conditions. Ectopic ACTH syndrome refers to excessive ACTH or adrenocorticotropic hormone production resulting from endocrine or non-endocrine tumors. ACTH independent Cushing syndrome is usually as a result of adrenal adenomas or adrenal carcinomas. The clinical features you all know about, which is the rounded face and the buffalo hump itself, along with the abdominal striae, right, and the weakened muscles in the upper limbs and the legs, the weight gain, and the buffalo hump, which usually occurs here at the back, and the increase in facial hair, which is common in women. Most common clinical findings include central obesity and facial rounding, right? Peripheral obesity and fat accumulation. The buffalo hump tends to be non-specific. There is increased supraclavicular fat pads that are more specific for Cushing's syndrome. Cushing-induced osteoporosis occurs in approximately 60% of patients, and back pain occurs in 40% of patients and is usually as a result of spinal compression fractures. Other common clinical findings include hypertension, glucose intolerance, cardiovascular disease, psychiatric changes, abdominal striae, muscular weakness, particularly of the upper limbs and the lower limbs, myopathy or muscle pain, facial plethora or reddening, and hirsutism and amenorrhea in women. You can also have problems with the spine, which result in osteoporosis and spinal fractures as well. Now, the way to diagnose Cushing's syndrome is to look at urinary free cortisol levels as well as midnight cortisol levels at approximately 11 p.m. to determine control. The third test, or probably the most important test, is the low-dose dexamethasone suppression test. So screening for Cushing's syndrome requires you to obviously do a low-dose overnight dexamethasone suppression test where you administer 1 milligram of dexamethasone orally close to midnight, around 11 p.m. normally. You then measure the plasma cortisol levels at 8 a.m. in the morning after some breakfast. In normal patients, of course, the plasma morning cortisol level will be suppressed to less than 50 nanomoles per liter. If the plasma levels are more than 50 nanomoles per liter, this will give you an indication that potentially the person may have Cushing's syndrome, right? It's important to remember that 8% of patients with Cushing syndrome will have a dexamethasone suppression test that is less than 50 nanomoles per liter. Therefore, other clinical criteria which suggest hypocortisolism will be required, right? Even if dexamethasone suppression tests suggest that cortisol levels are actually being suppressed. Part of this may be to do with the fact that the person may be taking other medications such as phenytoin, phenobarbital, and rifampicin, which can of course accelerate the metabolism of dexamethasone, causing a lack of cortisol suppression. Estrogen and during pregnancy, as well as oral contraceptives or estrogen replacement therapy, may also cause a lack of dexamethasone suppression as well. Patients with abnormal dexamethasone suppression, right, will require you to collect a 24-hour urine sample for urinary free cortisol levels. An abnormally high 24-hour urine free cortisol level of free cortisol to creatinine of greater than 95 micrograms per gram will help you to confirm the diagnosis of hypercortisolism. However, you can get a misleading result in patients who have a large fluid intake. In pregnancy, urine-free cortisol is normally increased, while 17-hydroxycorticosteroids remain normal, and diurnal variability of cortisol levels is considered to be normal as well. Remember that a midnight serum concentration of cortisol levels greater than 7 micrograms per deciliter is very indicative of Cushing syndrome and distinguishes it from other syndromes associated with high urinary free cortisol levels, such as pseudo-Cushing's, for example. When it comes to localizing the cause of the Cushing syndrome, MRIs of the pituitary demonstrate pituitary lesions in approximately 50% of cases. Premature cerebral atrophy is often noted on the MRI itself. When pituitary MRI is normal or shows a tiny less than 5 millimeter irregularity, this may just be incidental, and selective catheterization of inferior post-rosal sinus vein draining of the pituitary is then performed. CT scans sometimes fail to detect the source of ACTH in approximately 40% of patients with ectopic ACTH secretions. And for this, you may actually need to then do a scan using octreotide as such, but that is a bit beyond this particular course, and we will not go too much in detail into that particular section. Adrenal nodules and masses are identified with high-resolution CT scanning or using an MRI. The goals of therapy are, of course, to limit morbidity and mortality and return of patients to normal functional state by removing the source of the hypocortisolism and while minimizing pituitary and adrenal deficiencies is generally what is required. Management is generally based on the etiology. Pharmacotherapy is generally part of the second line management of this condition in patients who are obviously not surgical candidates. Pharmacotherapy may be used post-operatively for certain patients or as an adjunctive therapy in post-operative patients who are waiting for a response. Right? Monotherapy with pharmacological agents has its own set of uses and may be useful in certain scenarios. Primarily, single-use or monotherapy with pharmacotherapeutic agents is used for palliative treatment when surgery is not indicated. Non-pharmacological therapy for both ACTH-dependent and ACTH-independent Cushing syndrome deals with surgical resection of the offending tumor. Transphenoidal resection may be required and is the treatment of choice when it is a pituitary tumor. Pituitary irradiation provides clinical improvement in approximately 50% of patients in approximately 3 to 5 years. Laparoscopic adrenalectomy, that is the removal of a portion of the adrenal gland, may be preferred in patients with unilateral adrenal adenomas or for whom transphenoidal surgery and pituitary radiation has failed to actually treat the condition, or alternatively these cannot be used. Now, like we said before, the pharmacological treatment is primarily dependent on the etiology. So if you have ectopic ACTH syndrome, the non-drug therapy includes surgery, chemotherapy, and potential irradiation. Treatment with drugs includes metirapone and ketoconazole. Metirapone should be given initially at 0.5 to 1 gram per day, so 500 milligrams to 1 gram per day, divided equally every 4 to 6 hours, and giving it, and in a usual range you may need to go up to 1 to 2 grams per day every 4 to 6 hourly. So if you were going to go say 1 gram per day every 6 hours, that would approximately be 250 milligrams every 6 hours, or 2 grams per day will be 500 milligrams every 6 hours, up to a maximum dose of 6 grams per day, which is approximately 15 to 1600 milligrams divided into 4 doses. Right? Ketoconazole, on the other hand, may be given at 200 milligrams once or twice per day, and the usual dose is anywhere between 200 to 1200 milligrams given twice a day. So either 100 milligrams BD all the way up to 600 milligrams BD as the eventual treatment. There is a mistake on the slide. For 6 grams per day is 1500 milligrams of metirapone divided up 4 times a day. When it comes to pituitary-dependent Cushing syndrome, the non-drug therapy includes surgery and irradiation. You have a multitude of drug therapies you can use. You can use metadone, metirapone, mifepristone, or carbogoline, or perseriotide as required, right? And each one of them has a slightly different dosing regimen, right? The metirapone dosing regimen must be 1500 milligrams 4 times a day as the maximum dose, with a usual range of between 250 to 500 milligrams every 6 hourly. The metatone dose will be anywhere between 0.5 grams to 1 gram per day, increased by 0.5 grams or 500 milligrams to 1 gram every 1 to 4 weeks, and roughly 1 to 4 grams should be used with food to decrease the GI adverse effects, with a maximum dose of 12 grams per day. Mifepristone, which you guys might know from as a drug which is generally used as part of an abortion regimen, then you can use it approximately 300 milligrams once per day, right? And mifepristone is a progesterone and glucocorticoid receptor antagonist which inhibits dexamethasone suppression and increases endogenous cortisol and ACTH values in normal subjects. Limited experience is available and limited evidence is available for the use of mifepristone in Cushing syndrome, right? But there is some evidence which suggests it may be highly effective in reversing manifestations of hypercortisolism. But its use remains investigational, and that I think is very important to note. On the other hand, carbogoline can be used at 0.5 milligrams once a week, and you can even go between 0.5 milligrams and 7 milligrams once a week to a maximum dose of 7 milligrams per week. Remember, with carbogoline, to watch out for orthostatic hypotension, dizziness, and GI adverse effects. These will generally get better the longer that the patient takes it or the lower that you make the dose, right? Perseriotide is anywhere between 0.6 and 0.9 milligrams twice daily as the initial dose, with a usual range of 0.3 and 0.9 grams twice daily up to a maximum dose of 1.8 milligrams per day. For adrenal adenomas, you may need to consider surgical recession or an adrenonectomy, with the post-operative replacement of adrenal hormones being required. Drug therapy includes ketoconazole, right? And ketoconazole may be 200 milligrams once or twice per day, with a usual dose of anywhere between 200 to 1200 milligrams divided twice per day. So anywhere between 100 and 600 milligrams BD is where you're looking at. For adrenal carcinoma, the non-drug therapy includes surgery, so removal of the carcinoma itself, along with drug therapy in the form of metatone. Metatone is used at the same dosages we've discussed previously, up to a maximum daily dose of 12 grams per day. Metirapone inhibits 11-beta-hydroxylase, which then inhibits cortisol synthesis. Patients can demonstrate increased plasma ACTH concentrations because of a sudden drop in cortisol levels, and the adverse effects as a result of this may be hypertension, acne, and hirsutism. And other adverse effects include nausea, vomiting, headaches, abdominal discomfort, and allergic rash. Metirapone is primarily considered for compassionate use in patients. Ketoconazole, on the other hand, inhibits cytochrome P450 enzyme, and in so doing inhibits 11-beta-hydroxylase and 17-alpha-hydroxylase. It's effective in lowering serum cortisol levels after several weeks of therapy. Essentially, it has anti-androgenic activity, which is extremely beneficial in women, right? Because what it does is it it actually reduces androgen levels in women, but in men what it tends to do is it tends to cause gynecomastia and decreased libido. It also commonly causes elevations in serum transaminase levels, right? And GI discomfort and dermatological reactions can happen as a result of this. Now, this is the same ketoconazole that we say is hepatotoxic and is something to be aware of when you are actually using it as an antifungal agent. And when using it in Cushing's syndrome, you must also be aware of that. Ketoconazole may be considered when concomitantly with metyrapone, and it's used to achieve a synergistic reaction in cortisol levels. In addition, the anti-androgenic actions may offset the androgenic potential of metyrapone, and I think that is the primary use why we would use them concomitantly. Other agents include etomidate, which has a similar mechanism of action to ketoconazole, is only available parenterally and has limited use in patients with acute hypercortisolism and is primarily used for emergency cases. Metadone takes weeks to months to exert its effect. Right, so while it takes a while for ketoconazole to actually exert its effect, roughly taking several weeks, metadone can take anywhere between weeks to months. And sustained cortisol suppression in most patients may persist after discontinuation of the drugs. Of course, metadone degenerates cells within the zona fasciculata and reticularis. The zona glomerulus is minimally affected during acute therapy but becomes damaged after long-term therapy. Right, and it can of course cause neurological and GI adverse effects, and patients must be monitored carefully. Nausea and diarrhea are common when doses exceed 2 grams per day, and can be avoided by gradually increasing the dose, which is extremely important to remember, and also when administering it with food. So either gradually increase the dose or alternatively administer the drug with food. The most common neurological adverse events include lethargy and somnolence, and reversible hypercortisolemia may occur along with prolonged bleeding when you use metadone. Cyproheptadine, right, can decrease ACTH secretions in some patients with Cushing's syndrome. However, its side effects such as weight gain and sedation tend to limit its use. Mifepristone we've discussed in detail, and we've said that its use remains investigational. Using to evaluate the therapeutic outcomes, we would closely monitor urinary free cortisol levels, and serum cortisol levels are essential to identify adrenal insufficiency. Steroid secretions must be monitored with all drug therapy, and in some cases glucocorticosteroid replacement may be required. In this scenario, we would either use hydrocortisone or prednisone as necessary in the meantime to actually replace glucocorticosteroids. Now, generally after pituitary surgery, the rest of the pituitary returns to normal function. However, pituitary corticotropes can remain suppressed for up to 6 to 36 months before they will actually return to normal function, and this is the primary reason why we need to monitor steroid secretion. Complications of Cushing's syndrome include, if untreated, severe morbidity and death. The patient may also suffer from complications of hypertension and diabetes and may be highly susceptible to infections. Other things that we've discussed include compressions and fractures that may occur, as well as aseptic necrosis of the femoral head, which may lead to disabilities. Some patients may experience psychosis and nephrolithiasis or kidney stones as well. There may also be, due to a pituitary adenoma that is particularly large, visual field defects and hyperpigmentation, which is also a this particular complication is known as Nelson's syndrome. Now, let's discuss adrenal insufficiency. Primary adrenal insufficiency, sometimes known as Addison's disease, must involve the destruction of all regions of the adrenal cortex. There are deficiencies of cortisol, aldosterone, and various androgens, and levels of CRH and ACTH increases in a compensatory manner as a result of that. And an autoimmune dysfunction is usually responsible for 80 to 90% of the causes in developed countries, right? Of the primary adrenal insufficiency, and TB is the cause in developing countries, and some causes may be heterogenic in that we don't know what the cause is. Secondary adrenal insufficiency results from exogenous glucocorticosteroid use or from use of large amounts of glucocorticosteroids for a long period of time. This leads to suppression of the hypothalamus pituitary adrenal axis, which then decreases the release of ACTH, right, and results in impaired androgens and cortisol production. Mirtazapines and progestrogens may also induce secondary adrenal insufficiency. Other causes of adrenal insufficiency include medications that inhibit cortisol synthesis, such as ketoconazole, or those which increase metabolism of cortisol levels, such as phenytoin, rifampicin, and phenobarbital. Those all can lead to primary adrenal insufficiency. The common clinical features include weight loss, dehydration, hyponatremia, hyperkalemia. Elevated levels of BUN are very common in Addison's disease. Hyperpigmentation, common in Addison's disease, may involve exposed and non-exposed parts of the body. Now, when it comes to secondary adrenal insufficiency, hyperpigmentation is not seen, and this is because of the low amounts of melanocyte stimulating hormone that is released in secondary adrenal insufficiency. Now, short-term cosine-tropin stimulation tests can be used. Cosine-tropin is a very nice way of saying ACTH stimulation tests. An increase of cortisol levels to 500 nanomoles per liter or more generally rules after the administration of ACTH generally rules out adrenal insufficiency. Some texts say 500 nanomoles per liter. Some texts say 550 nanomoles per liter. Patients with Addison's disease have abnormal responses for short-term ACTH stimulation tests. The plasma ACTH level, right, is usually elevated anywhere between 400 to 2000 picograms per mole, or 80 to 440 picomoles per liter in primary adrenal insufficiency or Addison's disease versus low to normal in secondary adrenal insufficiency. It's important to remember that a normal ACTH stimulation test or cosine-tropin stimulation test does not rule out secondary adrenal insufficiency. Other tests may include insulin hypoglycemia test, the metirapone test, and the corticotropin releasing hormone stimulation test. The goals of therapy essentially are to limit morbidity and mortality, to return to a normal functional state, and to prevent acute adrenal insufficiency. Non-pharmacological therapy. Patients must be informed of the need for treatment compliance and the expected outcomes, and proper medication administration and adherence as much as possible despite potential side effects. Hydrocortisone, cortisone, or prednisone are the drugs of choice. They should be administered twice a day at the lowest effective dose because this mimics diurnal rhythm of cortisol levels. Hydrocortisone anywhere between 12 to 25 milligrams daily, cortisone anywhere between 25 and 37.5 milligrams daily, and prednisone 2.5 milligrams daily. 2/3 of the dose should be given in the morning, with the last 1/3 of the dose being given 6 to 8 hours later. Patients must be monitored for every 6 to 8 weeks to address or to assess proper glucocorticosteroid replacement. In the case where a patient may have hyperkalemia, you may need to consider the use of fludrocortisone acetate orally, anywhere between 0.05 milligrams to 0.2 milligrams once daily. Adrenal crisis may occur in patients due to a lack of glucocorticosteroid dose reductions or a lack of steroid-related dose adjustments. In these patients, you should add 5 to 10 milligrams of hydrocortisone or equivalent to their normal daily regimens before strenuous activity or exercise. During times of severe stress, patients should be instructed to increase their dose until recovery, and this includes situations in which the person gets sick, or alternatively they would of course be going for some kind of elective surgery as well. They need to double their dose until recovery. Treatment for secondary adrenal insufficiency is the same as primary, but there is no need for mineralocorticoid replacement. In the case of an acute adrenal insufficiency, which is a true endocrine emergency, it has a number of causes. The most common cause is abrupt withdrawal of exogenous steroids. So abrupt withdrawal of glucocorticosteroids in patients can result in this, and this is usually then as a result of suppression of the hypothalamus pituitary adrenal axis. So this will commonly occur in patients who have been taking long-term glucocorticosteroid therapy, right? And the way to treat them is IV hydrocortisone by a rapid infusion followed by continuous infusion of 10 milligrams per hour, or an intermittent bolus of 100 to 200 milligrams every 24 hours. Fluid replacement is often required by IV dextrose 5%, and hyperkalemia may be present in the hydrocortisone maintenance phase, right? That is the point after rapid infusion, and in that case you may need to use fludrocortisone acetate 0.1 milligrams per day. It's important to remember that stressful situations, surgery, infections, and trauma are potential events that can lead to acute adrenal insufficiency, right? As well. Patients with adrenal insufficiency should carry around a card or wear a bracelet or a necklace that contains information particularly about their condition. They should also have easy access to injectable hydrocortisone or glucocorticosteroid suppositories in case of an emergency or during times of physical stress such as febrile illness or injury. Obviously with surgery you'll have them in hospital, and you'll notice when there is acute adrenal insufficiency. Evaluation of therapeutic outcomes. One should look for a reduction in excessive pigmentation, which is a good clinical marker, and development of Cushing syndrome, which could indicate excessive replacement of glucocorticosteroid levels. Pheochromocytoma is the last condition that we'll discuss. Remember that pheochromocytomas arise from tumors which are found on the adrenal medulla, which usually secrete both epinephrine and norepinephrine. The excessive amount of epinephrine will cause tachyarrhythmias. The tumors may be located either on both or anywhere along the SNS chain, or somewhere in the mediastinum, heart, or bladder. Right, and tumors may be located in either or both adrenals or anywhere along the SNS chain, sometimes in the mediastinum, heart, or bladder. Particularly dangerous and deceptive is the condition of pheochromocytoma, and leads to death in approximately 1/3 of patients, and accounts for 0.4% of hypertension. The incidence of pheochromocytoma is higher in children and patients with moderate to severe hypertension, particularly those who present with hypertension in the presence of a headache, significant palpitations, and excessive sweating or diaphoresis. Right, the clinical signs and symptoms are a plethora. You might get hypertension, which is severe or mild, or paroxysmal, which means it comes and goes or is sustained. It may even be orthostatic in nature, where you may have orthostatic hypotension, shock, and even normal tension as well. You may also develop patients may also develop vasospasms, which lead to cyanosis, Raynaud's phenomenon, gangrene, or severe radial artery vasospasm with a thready pulse and a falsely low blood pressure by radial artery transductors. Multisystem crises include severe hypertension, hypotension, fever, encephalopathy, renal failure, acute respiratory distress syndrome, and even death. Gastrointestinal symptoms include abdominal pain, nausea, vomiting, intestinal ischemia, right, which can lead to loss of small bowel or large bowel depending on where it occurs, pancreatitis and cholecystitis, jaundice, rupture of an abdominal aneurysm or an AAA, constipation, and even toxic megacolon. It may also cause hyperglycemia, diabetes, lactic acidosis, and fevers, headaches, paresthesia, numbness, CVAs such as cerebrovascular accidents, TIAs, strokes, hemiplegia, seizures, even hemorrhagic strokes, metastases, and also may occur. Metastases may impinge on brain structures, which may lead to optic nerve damage or other cranial nerves. There may also be spinal metastases as well. Dyspnea and hypoxia from acute respiratory distress syndrome may also occur. Psychiatric problems will include anxiety, depression. Common symptoms include psychosis as well. And of course, renal symptoms include renal insufficiency, nephrotic syndrome, malignant nephrosclerosis, and large tumors which involve the kidney and the blood vessels. There are even more clinical features. Some are related to the skin, where you may get apocrine sweatings during paroxysmal episodes of your pheochromocytoma, drenching sweats as an acute attack. You may also get eczema and mottled skin as well. Ectopic hormones such as Cushing syndrome, Werner syndrome, and hypercalcemia and erythropoietin levels may also be increased. So ACTH, erythropoietin, all may be increased. Children most commonly will have sustained hypertension, diaphoresis, headaches, visual changes, polyuria, polydipsia, seizures, edematous or cyanotic hands, and most commonly will harbor some kind of germline mutation, multiple tumors, or alternatively some kind of paragangliomas as well. In pregnancy, hypertension will of course mimic eclampsia, and hypertensive multisystem crises will occur during vaginal delivery. Postpartumly, you may get shock or fever, and this tends to have a high mortality rate in pregnancy. Generally, your laboratory findings will include leukocytosis, eosinophils, and erythrocytosis as well. Now, testing for tumor markers may yield only minor elevations, and approximately 10% of hypertensive patients have misleading elevations of one or more of these tests. The ideal test is a plasma fractionated free metanephrine level. Now, metanephrines are actually the byproduct of the breakdown of catecholamines. In other words, if you have a large amount of catecholamines such as epinephrine and norepinephrine, when they are broken down, they will release metanephrines, and therefore it's the most sensitive test for secretory pheochromocytoma levels, right? Plasma levels of free metanephrine fluctuate and are lower in patients that are supine and when ambulatory, right? For practicality purposes, the blood specimen is usually obtained while the person sits quietly in the laboratory for at least 15 minutes. And I think that this is extremely important. They need to be sitting quietly, not in a supine position, in the laboratory for at least 15 minutes. Urinary fractionated metanephrines and of course creatinine are effectively used to confirm most pheochromocytomas that have of course been detected using plasma fractionated free metanephrine levels, and this requires a 24-hour urine sample. Patients with pheochromocytomas generally have a total of more than 2.2 micrograms of total metanephrine per milligram of creatinine, right? And serum CGA levels will also correlate with the tumor size that the patient may have. And serum chromogranin levels, which is serum CGA levels, are elevated in roughly 90% of patients with pheochromocytoma, and the levels obviously correlate with tumor size being higher in patients with metastatic disease. This level, however, can be misleadingly elevated in patients with pre-renal azotemia or acute kidney injury, and of course hypergastrinemia as well, and is treated with and in those patients who are treated with glucocorticosteroids or proton pump inhibitors as well. Right, the other way to diagnose it is using a clonidine suppression test. And essentially, a clonidine suppression test helps to distinguish whether elevated free normetanephrine levels are physiological or indicative of a pheochromocytoma. Plasma free fractionated metanephrines are usually measured before the administration of 0.3 milligrams of clonidine and then 3 hours afterwards. A fall in the plasma metanephrine level into the normal range or greater than 40% from baseline helps us to rule out the presence of a tumor. CT and MRI are imaging that should not usually replace biochemical testing, since incidental adrenal adenomas are very common and can be misleading. When a pheochromocytoma is suggested because of biochemical testing or genetic testing or predisposing factor to pheochromocytoma, a CT scan of the abdomen is generally then performed within the section of the adrenals. MRI has the advantage of not requiring intravenous contrast dye, right? It lacks radiation, making the imaging that of choice for pregnancy and of course that in children. So essentially, CT scans of the abdomen are extremely important once you have established that there is a possibility of pheochromocytoma after you have done your biochemical testing, right? But MRIs are much more better in terms of them not needing contrast dye and a lack of radiation, particularly in pregnant women and in children. Both CTs and MRIs have a 90% sensitivity rate for adrenal pheochromocytoma and a sensitivity of 95% for adrenal tumors over 0.5 centimeters in diameter. However, both CT and MRI are not sensitive for detecting recurrent tumors, metastases, and of course extra-adrenal paragangliomas, which may also lead to pheochromocytoma type symptoms. Nuclear imaging, right, using using a form of iodine scans can localize tumors with a 94% sensitivity and a 92% specificity as well. All complications of severe hypertension can occur in these patients, and that includes hypertension-mediated organ damage such as retinopathy, damage to the heart, kidney damage, etc. You may also have severe heart failure and cardiovascular system collapse, along with catecholamine-induced myopathy may develop. Sudden death due to an arrhythmia may also occur. Acute respiratory distress syndrome and multi-system crises may occur. After removal of the tumor, a state of hypotension and shock may also occur, and patients must be monitored after the tumor has been removed. The clinical management. Most patients must receive adequate treatment for their hypertension and tachyarrhythmias prior to the actual surgery. This may require the use of alpha blockers or calcium channel blockers, either separately or in combination with one another. The common alpha blocker that we use tends to be doxazosin at 4 milligrams given once daily, or maybe up titrated up to approximately 8 milligrams once daily. And in South Africa, the calcium channel blockers that we use the calcium channel blockers that we generally use include amlodipine 10 milligrams daily, or nifedipine XL 30 to 60 milligrams given once a day. It's worth noting that while you can use beta blockers in these patients, beta blockers must be used with extreme care, primarily because blood pressure control using cardiac selective beta blockers can be extremely dangerous, right? I think it's just worth pointing out in this scenario that when we're screening for pheochromocytoma, we must always bear in mind that we must be looking at younger hypertensive patients with paroxysmal symptoms, in other words, comes and goes, and patients with either a labile blood pressure, those with a family history of pheochromocytoma or neurofibromatosis, or anyone with radiological evidence of an adrenal mass. Just a reminder that radiological evidence of an adrenal mass could be incidental in finding and must be followed up, like I said previously, using biochemical testing. Alpha blockers are generally administered prior to surgery, and like I told you, doxazosin is a selective alpha-1 blocker with a half-life of approximately 22 hours and used in doses anywhere between 2 to 32 milligrams per day. The ideal alpha blocker is usually used at 4 milligrams per day. That's doxazosin 4 milligrams per day. It may be required to be up titrated to 8 milligrams per day to control blood pressure. Right? Optimal alpha blockade is achieved when the supine blood pressure is below 140/90 or as low as possible for the patient to have a standing arterial blood pressure approximately above 80/45. Calcium channel blockers are also effective and are usually added on to alpha blockers but may also be used alone. In South Africa, we can use calcium channel blockers like amlodipine at a dose of 5 to 10 milligrams per day. Nifedipine XL may also be used given orally at 30 milligrams, given roughly once a day, and may be increased as necessary up to a maximum dose of 60 milligrams twice daily. These should not be used in patients with severe heart failure. Nifedipine is quite successful in treating acute hypertension in patients with pheochromocytoma even at home. It is reasonably safe as long as the blood pressure is consistently monitored and carefully monitored at home. Beta blockers are often required after institution of alpha blockade or calcium channel blockade, but these must be used with extreme caution because they can cause paradoxical hypertension as part of the initial use. Labetalol is generally combined here. Now, we do not give diuretics to these patients unless pulmonary edema is present. Surgical removal of pheochromocytoma is generally considered to be the treatment of choice, and laparoscopic surgery is generally preferred but large and invasive tumors may require open laparotomies to actually treat. Prior to surgery, blood pressure must be controlled for at least 4 to 7 days using either alpha blockade or calcium channel blockade, or the combination of alpha and calcium channel blockade together. The ECG of the patient must be stable prior to this, and intraoperative severe hypertension must be treated with sodium nitroprusside anywhere between 0.5 to 10 micrograms per kilogram per minute. Tachyarrhythmias must be treated with atenolol as 1 milligram bolus doses. I think that comes to the end of this particular lecture, and if you have any more questions or any questions regarding these conditions, you are more than welcome or free to email me about these conditions. Thank you very much for your time.